wanted to thank everybody. I see we're recording now, so everyone know that we are recording this session. We're doing so that we can share it with folks that were not able to attend in person, as well as also we will be putting it up on our YouTube channel so that we can always reflect back on it and look at it so that we are sure that any of the questions that we have afterwards we can get answered. We will also be sending out a PDF of the presentation. So feel free to take copious notes, but just know ahead of time that you will be receiving the actual PDF as well. So I wanted to just thank you all for coming today and joining our very special presentation, utilizing the healing power of families for optimal treatment engagement and recovery. And I'm delighted to introduce our speaker today. It's someone that I worked with for 4 years and hold very near and dear to my heart, and that is Bonnie Brennan. She's a compassionate and mission-driven clinician, and I can vouch for that, having worked with her personally. She brings her knowledge and leadership in the fields of addiction, eating disorders, and mental health to support families and caregivers using evidence-based interventions, workshops, and continuing care models. And by utilizing the healing power of the family, even the most complex cases can find lasting recovery. Bonnie is a former leader of a large mental health care system for eating disorders, has been a licensed clinician for over 20 years, and is an engaging and compelling speaker and educator. And so with that, I'm going to turn it over to Bonnie, and everyone just sit back and enjoy. Before we do that, I will also let you know that afterwards we're going to mute everybody, but please feel free to start putting questions into the chat. And for the last 15 minutes, we will, or 15 to 25 minutes, we will answer all of those questions as they come in. Thank you so much. And Bonnie, I'm going to mute and let you take it away.
Well, Laura, did you want to say a bit? Your lovely sponsors.
Yeah,
did you want to say a bit about your sites? I have a little slide here of gratitude for you, so I'll just pull it up.
Oh.
Yeah, there we go. Thank you so much. So Laura, do you want to go first since you're alphabetically appropriate?
Oh, sure. Hi, guys. My name is Laura Martinez, and I am the outreach manager for AspenRidge Recovery. We are a dual diagnosis facility, and we are specializing in substance abuse, mental health, and trauma. And we currently have 3 locations, our Fort Collins, Lakewood, and Colorado Springs locations. Our highest level of care right now is an in-house transitional program, essentially PHP, and we do have the option of our recovery residences in Lakewood and Fort Collins. Otherwise, our Colorado Springs location is just our standalone evening IOP, and we also have that program at our other 2 facilities, as well as our online version we call Reach. It's our online platform that is the same treatment that people are receiving in in-person IOP. It's just on our online platform, and that we're actually moving to more of a nationwide program, hopefully here in the near future. But otherwise, we do have that for all Colorado residents. Our most recent news is we are now in network with TriWest, TRICARE, and a non-HMO version of Beacon, which is just going to be out of our Lakewood facility currently. But otherwise, we're super excited for the new year and hopefully getting back to some more in-person therapy options. But right now, we are 100% virtual. So that's what we have going on at AspenRidge right now.
Hey, thanks, Laura.
Sure.
And I am Laura Herman, and I work at Gallus Medical Detox. We are 2 freestanding private medical detoxes, one in Scottsdale, Arizona, the other one right in Littleton, Colorado. We basically do things very different. Our differentiators are that we have 6 beds. Each person has their own individual bedroom with a queen-size bed, a flat screen TV, and we do things through a Gallus method of detox, which is a proprietary method working both with how we work with patients and keeping them engaged for next levels of treatment, as well as also our IV method of detox, which provides a more pleasant detox. I will not say pain-free because that's close to impossible, but much more pleasant, as well as also a shorter length of stay so that our patients can get back to you, the referring population, much faster. We have a full-time medical doctor at each one of our programs, as well as a clinical director. So they're meeting with both a medical and clinical person every single day, as well as doing a full biopsychosocial and then ongoing to make sure that stages of change and the next levels continue to be a motivation for them. Everything we do is very patient-centric as well as very referent-centric. So we do such things as black car pickup from airports, as well as also do a lot of hands-on communication. We can take very high medical acuity as well as very high levels of detox needs. An example of that is we can take someone at 300 milligrams of methadone. So we really are a center of excellence across the United States and can do things that most others cannot. And in October, our patient satisfaction score for both was 100%. So we're definitely doing something right. We've been around for 10 years and we are in a bit of a mode of some exciting news to be coming at the beginning of next year. And so we're really looking forward to that. So thank you for giving me a moment. And Bonnie also has all of our contact information on her first slide. Feel free to reach out to us afterwards if you have any other questions.
Yeah, beautiful facility there at Gallus. I had a nice opportunity to go visit when they were having a clean day with no one there. So it was really nice if you get a chance to go take a visit. All right, well, let's launch into why. So first of all, why am I here speaking with you all? And, you know, I think that we've learned a lot of lessons this year. 2020 has certainly taught us lessons, some that we may have wanted to learn and some that we may not have wanted to learn. And for me, I think my lesson is that kind of that facing of my own mortality, you know, like people that I knew were sick and I was fearful of getting sick and thinking about if I had, you know, 10, 15 more years of doing what I love to do and helping people, can I say that I have done what I needed to do? And the answer was yes, and I have trained clinicians and other professionals for many years and worked with clients with eating disorders and addictions and all the things that come with that, you know, all kinds of mental health issues. But what I really had felt like I was not doing more of was supporting families. So I made a very conscious decision this year to step away from a leadership role that had served me very well, very scary decision. But I really felt like I needed to spend some time in helping families be able to navigate the mental health challenges, and especially in a time of crisis. And in particular, in the eating disorder space, which is one of my expertise, there just really aren't interventions for eating disorders. There's maybe a handful of people that do them nationwide. So I made a commitment, went to visit Arise and got trained in their Arise model. And I'm doing interventions now for families with eating disorders. And I also believe in helping clinicians to be able to embrace why it's so important to be able to include them as part of your treatment. And for some of that is to help with your own burnout, because folks with conditions that are likely to reoccur with new traumas and events that happen in life that are outside of our coping skills are going to need support ongoing. You know, you just don't get to a place where you do a quick bout in treatment and you're recovered, period. It takes a long time. And then also families also have their own opportunities to heal. And we'll talk about that. Oftentimes the person who has the most problems right now is actually the best opportunity to lead a family system into health. So today I'm hoping to help you with how to leverage some family support and why to involve families, to provide some guidance and some skill building through EFFT, and also to start to create a plan of engagement for the recovery process during and after a treatment episode. So here's some information of why should we involve families? Well, years and years ago, decades ago, there was actually a therapeutic technique called the parentectomy. And the belief was well-intended, you know, of course, we weren't trying to do harm, but well-intended belief that the parents were the cause of somebody's addiction or someone's eating disorder, and that we had to remove them from that toxic system where they had been parented incorrectly and reparent them ourselves as clinicians and launch them into the world now with the best opportunity that they have for recovery. However, there's some challenges with that. And one of them is we found out that people don't actually leave their family system. Even, and I've had this experience too, you know, like people come in for treatment, they say nobody's involved in my care and I don't want you including my family. And then I might hear from floor staff in a residential setting, like, she's screaming to somebody on the phone every night. You know, I don't know who that is. And it's most likely the family member. And there was actually some really fascinating studies on substance users where the general myth was that the person who was addicted or dependent would separate themselves from the family and be really isolated. But actually the very opposite was true, that people with substance use disorders tend to be actually more in contact with their family than so-called normal controls, and even contact them at more frequency than you or I would. So they do tend to be still involved with their family, and the families are usually able to locate where they are. So another myth is that, you know, they've dropped out and we don't know where they are, but that is not true either. And then something that also that's really interesting is that you don't have to wait for somebody to be self-motivated or to have to hit bottom to actually get well. The research bears out that the number one reason why people engage in treatment and get better in the addiction space anyway is the legal system. Sorry about it. Can you guys hear that barking dog? That thing is, I might have to jump out and put her outside. I think she's stopping. So you don't have to actually wait for the person to hit bottom. So what the research shows us is that the legal system, number one reason that people enter and engage in treatment and stay in treatment. And number two is families. So that, you know, a lot of times the families believe, or we believe as clinicians, well, they got to really want it for themselves. But what happens is, and anybody who's going through any kind of recovery is going to have some ambivalence. You know, they had what they did, whether it's thoughts of suicide or the eating disorder behaviors or their addiction, is oftentimes treating stuff that's very painful. So it's easy for them to make the decision in their mind, well, maybe this isn't for me, maybe I can control it myself. So families are a really important factor in not only helping people to get into treatment, but to stay the course through a treatment episode and beyond. And then we have another factor that I've had more, I don't know, I guess I've spent more time with recently, the last 10 years. That is neuroscience is really teaching us about oxytocin-based bonding, meaning that feeling that you get when you're in love, or for those of you who have had babies, like that rush of having the baby in your arms, you know, becoming a new parent for the first time. And it's just that overwhelming, connecting neurochemical. And with our family members, whether we're fighting with them right now or cut off with them, those folks who we have had an experience of love, even if there has been dysfunction in the family, are actually going to be connected to us neurobiologically for the rest of our lives. We'll always have a connection. And, you know, I've seen this bear out in talking with clients about, you know, they'll say like, oh, well, I don't speak to my father. And, you know, I'll say, oh, that's interesting. And then you hear the blah, 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 all this painful stuff, all these painful emotions, because they're still affected, even though they may have been cut off and not talking with them in their mind. You know, our emotions actually don't follow the same like time cycle as our lives do. They stick in there. And you know that when you've been triggered and taken right back at Christmas time, holiday time, there's a lot of opportunities for us to be taken right back into memories of childhood, good things and bad, right? For me, it's like putting up that ornament on the Christmas tree that I've had forever. Can remind me of like, oh, my boys are grown up and I really miss them as babies. You know, I have an emotion right away without, you know, even wanting to go into that space. And so once we're connected, we're going to always be affected. And, you know, think also your first love, that could be Another thing to think about too, we fall in love with somebody, we maintain a little connection with them, even if we're not speaking with them. And then another thing that's very interesting to note too is that, even though therapists are really well-meaning, they're not connected via oxytocin-based bonding. They can have love and positive regard for the human that they're treating, but they don't have the same connections. And they're not actually as powerful as a family member if the family member is taught the same skills. So a goal of mine is to help family members get the same skills that I've been training clinicians in for many years. So the faster way to actually teach a brain is to teach it with a brain that's wired to them. And I'm going to give you some of those skills today too. And also, as you probably well know, that persons with mental health challenges, addictions, and eating disorders are oftentimes living at home or some way dependent on their parents or family members, grandparents, for financial resources or living situation. And they can provide a better picture of symptoms. I won't, even if I have somebody come to me for individual work, I still tell them at some point I want to talk to somebody who's in your life that supports you, because they see you in a different way and you present to them in a different way as well. So they can be a really valuable resource, and they're going to have the most regular contact. A clinician is, they're going to have life happen to them. People get pregnant, they move away, they get sick, they might have to they change jobs, but our family members stay our family members. So best to get them in the room and start to train them. And actually the UK has led the way on this. They do have now, the mental health system has a benefit. You don't have to have a problem to get some support, mental health support, if you're a family member of somebody who has like an eating disorder or an addiction, right? So right now in the United States, how we work it, if somebody were to say, Bonnie, I need some help with my daughter who has an eating disorder, can you help me? They can come to me for therapy, but I have to diagnose them, right? If they're using their insurance, I'm supposed to be diagnosing them with a problem. Well, maybe they're not having a problem other than I'm distraught, So the UK is really leading the way on this. So more to come on that. I hope that we can follow suit in the next few years. All right, so a little note on transition and loss in families. And just moving my gallery here so I can see this slide. So we have Judith Landau did a lot of work in this, Landau and Garrett. Judith is the founder of Arise. She's here in Colorado, for those of you who don't know her. Really interesting woman to get to know, and has done so much work on helping us understand why families are so important in the process of getting well. And one of the things that she's really, she has a nice TED Talk if you want to check that out on YouTube. It's like a TEDx in Vail, where she talks about this. Regardless of genetic factors, the onset of addiction is almost always connected to the death of a parent, a grandparent, spouse, child, or significant friend, abuse in the system, natural or man-made disaster, war, immigration, refugee experience, random acts of violence, and pandemics, I should have added there, right? Big things that are so big that they are beyond our available coping skills in the moment. And as somebody, myself, who has done genograms, which is a way of creating a family tree that is targeting like what's happened in the family. Has there been physical illness? Has there been substance use, mental illness, that sort of thing? And even doing that with my own family, you start to see like, wow, yes, the families are oftentimes dealing with so much grief and trauma that we just kind of compartmentalize, because that's what we've been taught to do with emotions. My family system, the way we handle emotions is to get to work, pull up your bootstraps. If you, on my father's side of the family, if you need to have emotions, that's what confession is for. You go to the priest and you talk about that kind of stuff. But we don't really talk about emotions. We get to work, and then if you need to feel them, go take a bath, maybe. And then, like, and also when families are in transition, it's also a time when you're going to see problems start to arise. And transition can be good stuff. Transitions can be planning a wedding. It could be children leaving for college. Oh my God, my first baby going to college. So proud, and like 3 months of crying at the same time. The transitions are just difficult because things are changing in the family. So whenever a family is having 3 or more transitions in a short period of time, that's also time to be like on the lookout that it's likely that there are going to be mental health challenges or addictions, especially if the family has had a pattern of that. And Landau and her team have also trademarked the family motivation to change concept, which I think is really, really helpful for us. So when families have been, like, you think about a family who has immigrated or had to drop everything from their country of origin and start over in America, right? Which is a dream for a lot of folks, maybe not lately, but certainly in the past. And many of us have the story of a family member who immigrated from someplace else. And lots of stuff can come up with that. We oftentimes, or we may have lost people to wars and disease, and it can take up to 3 to 5 generations for family members to resolve grief and challenges and losses that they've gone through. And what happens is oftentimes that an addiction or an eating disorder will come in and almost rescue the family from this like devastating grief. It's almost as if the family has an easier time, not on a conscious level, has an easier time wrapping their mind around like somebody's drinking is too problematic right now than they do for them all to grieve the losses that they have. So the family then starts to come together to problem solve the addiction of the moment or the eating disorder at the moment. And the challenge with this is then the person who has the behavior who's also affected by this generational pattern of grief and trauma is becoming, the person in the middle who everybody's pointing their finger at, but really everyone's struggling. They're just like kind of using the addict as the person to look at who's demonstrating the pain of the family, if that makes sense. And because there's a natural motivation for families to, we're kind of wired, again, going back to that neurobiological connection, we're wired together, we're wired to survive. And because of that, sometimes, and most likely after 3 to 5 generations, somebody's going to spring up that can lead the family into health. And here is your opportunity. This is your opportunity. The one that the family is organizing around because of the problem is actually the biggest opportunity to help this family get well. So how do we start to do that? Harnessing the healing power of these families. And we're going to learn some emotion-focused family therapy now. So emotion-focused family therapy developed by Adele LaFrance and her colleague. There's a book here, the picture of the book that came out last year, very helpful. I recommend it for folks in the helping profession. You don't have to be a trained therapist to do this. So this is like any nurses or recovery specialists, for example. You might want to get your hands on it if you're interested in what you're learning today, because what we're learning is actually coachable skills that you can do without an advanced therapy degree. And emotion-focused family therapy has 6 pillars that they are in alignment with, and I'm in alignment with as well, which is that we've got to empower caregivers and help them to be involved. There's a focus on emotion processing, and we'll get into that in a minute and why that is. Why do we process emotions? As well as skill development. And our goal is to not to like single out the family members that are to blame, even those that have had that have wreaked havoc on the family can also be agents for healing too. So please don't discount them. And I know it can be hard. because we have our own judgments about how people have behaved within their family systems. The model believes in collaboration and transparency, which is also a great foundation for anybody working with a team in a treatment center and beyond. And then the 1 degree effect, which is that we're not going for having somebody completely to wellness wrapped up with a bow and put under the Christmas tree, right? We've done such a good job, but that if we can make a difference, even if it's 1 degree over a period of time, if you were to change, like if you're on a course in a boat sailing towards the horizon and you change that course 1 degree, it's going to end up in a much different place than where you started if you just keep going straight ahead. So even if we can make 1 little change, we're going to have a positive impact on the system over the long term. And this picture here is one that I like to pull up in my own mind when I'm having my own struggles as well. It's really the foundation of love and what happens when in our own attempts as caregivers, as clinicians, as human beings, to protect or help somebody else or ourselves when they can go awry. And it's usually when we're struggling with these emotions of fear, grief, helplessness, hopelessness, self-blame, and shame. And then when we experience those ourselves, we're more likely to behave in ways that are on the top part of the tree, right? They're more likely to use behavioral strategies that are actually counterproductive in our attempts to help ourselves and help other people. So engaging in the behaviors of defensiveness and blame, enabling and accommodating, being overly permissive or overprotective, denial, avoidance, criticism, and rejection. And if you as a clinician or professional can keep in mind that the roots of this tree are coming from a place of love, right? We're oftentimes coming from a place of love. And caregivers themselves will often say that they feel the most burnout from the feeling that their efforts to help their loved one isn't effective, that they aren't competent enough, that they've put in all of this time and nothing's changing and nothing's happening, and it's so draining. But it's coming from a loving place. They really want the best for their loved one, and they want, and even when somebody cuts off from the family, right? That person, that parent that walks away, many times that's the root of that is love. I'm just going to mess them up. I'm too broken, and this person would be better off without me. So we can really do counterproductive things coming from a place of love. So in EFFT, we want to always look at what is the loving protective function of what the person is doing, so we can reduce that feeling of shame and blame for them, and then help them to do something in a more effective way. All right, so here's if you're ready to pay attention and feel an emotion for yourself, now is the time to look at the screen. So why do we hesitate to include family members? Well, EFFT's developed this clinician traps and triggers scale. And I'm going to read these, and I want you to maybe, you can do a self-rating scale there. There's a from 1 to 7, when you can rate yourself as not likely, 7 is extremely likely, or you can just listen to me read each one and see if you can feel an emotional response for yourself. And you can think about for yourself, like why you might be hesitant to include a family member or recommend that a family member be included. Okay, so let's take a breath. And just listen to me say it and see what comes up for you. We hesitate because we worry that we're going to be disliked by the caregivers, that we're going to cause suffering to these caregivers, that we're going to go into an emotion and we're not going to know what to do with it or how to process it, that will put strain on a couple or the parent-child relationship or the carer loved one relationship. That we're going to push a caregiver too far and lead to the worsening of problematic symptoms or behaviors with like withdrawal or termination. We'll make decisions that might be unpopular with or contrary to the wishes of other team members. We worry about bringing in a critical or dismissive caregiver, leading to too much distress for the client. Oh, I'm going to make them worse. Having to face my own triggers or vulnerabilities or wounds along the way. I can't work with this because I'm going through this in my family. Being blamed or being to blame for lack of response to intervention, including having a complaint filed. The families can get pretty aggressive with that at times. I'm going to sue you. Blaming the client or caregivers for a lack of response to intervention. Feeling or appearing incompetent or lacking competence, or just simply becoming overwhelmed or burnt out. And then there's an opportunity there too to put anything else. So I would say in my career, I can identify with why I have hesitated with almost all of these, if not all of these at one time or another. And these are just our own emotional responses to the challenges. And it's hard. It's hard to be the helper in a system that has undergone a lot of grief and pain. You know, I've heard so many terrible stories, so much emotion that's there. And I just want to show you too that not only are we as the clinicians struggling with these emotions, but also same goes for caregivers too. So they have the same fears about making their loved one worse, putting a strain on their own relationship. And it's kind of reflective that this is a nice skill for them to fill out, similar to the one that we just walked through, worrying about causing suffering to their loved one. And it can really help you to understand their perspective and where the loving protective function is for why they're feeling like they either can't be involved or don't want to be involved or they're hyper involved. So ask yourself, when I am trapped or triggered, you're feeling like you're in one of those traps or triggers, what are you most likely to do? And let's go back to looking at the tree. So for example, when I'm feeling like trapped, one of my traps is that I'm going to push the caregiver too far. I'm going to push them too far and they're going to make everything worse. You know, they're just going to muck it all up. And so what I'll do is I'll tend to go into like a criticism or maybe overprotectiveness of my client. Or maybe even overprotectiveness of somebody in the family system. Oh, poor mom has been so hurt by all the actions of this family. That's not necessarily my best move. But just having an awareness of where you might go. We're all human beings with emotions, can help to just to heal with that 1 degree effect. Even your awareness of what you might be most likely to do in the presence of being triggered can be a big help. All right. So mental health challenges are things that require advanced caregiving skills. Not only do we not get a certificate on how to be a parent, you got to go to babysitting school to be a babysitter these days, but we don't have to, have to take any classes to be a parent. And certainly we're not taught on how to help somebody with an addiction, an eating disorder, or severe mental illness. So please, I don't expect anybody to be able to do this, much less like trained clinicians need years of continuing education to learn how to do it. But there are some things that we can teach to families. And one is just that awareness of your emotional blocks. That's what we were just talking about, things that might get stuck in the way, even though we have the most loving stance of wanting to help other people? What gets in the way of that? And we're working to understand the function of that behavior. And also that when we're activated in emotional states, we do behaviors that get in the way. They can leave the caregiver or the clinician feeling frustrated. So when somebody's entering treatment, oftentimes the family is at the worst point for them on problematic behaviors. They're traumatized, they have all these emotions, they're scared, they're worried, they're frightened, they're feeling helpless, and you're going to see the most problems that they're going to present are going to present at that time because they're traumatized. It's not how they normally are. And so don't let that first impression actually rule your diagnosis of the family or your assessment of the family. They're just in a heightened emotional state that will tend to polarize them into really extremes of behavior. And once we can help them to regulate, we can teach them then how to help the person that we're in charge of to regulate as well. So Janet Treasurer has done a lot of research in the UK and work with eating disorders, has a nice way of, I like these animal models because they help me remember in time. I'm not a great retrieval memory person. I never did well on those tests where they said, what's the facts here? Is it 1946 or 1948? I don't know. But I can remember these animal models. They help me. So I hope they help you too. So the types of emotional responses that people have will tend to be in a range. And these are the two extremes of the range. So extreme number 1 is the jellyfish range. And the jellyfish, the benefit of the jellyfish is they feel emotions, and they're often the person in the family that is expressing the emotions for everybody else. But the disadvantages of the jellyfish is they're kind of wobbly and they may struggle to keep emotions in check. They're usually the first ones to start crying. They give permission to others to start crying, and they can be a little wobbly. So think about yourself as we go through this, or do you tend to be on one end of the spectrum or the other? And then the other end of the spectrum for emotional responses is the ostrich, right? That's what my father, Michael James Brennan, he was great ostrich. He would just boom, head in the sand and let me wait till he had 3 daughters and a very, my mother was a Marine, so you can imagine the female power in the house. He would just wait till it's all over and then make everybody toast with peanut butter and it'll be okay. So the ostrich avoids the seeing and the thinking and the dealing with emotions. And there's sometimes the ones that will think of how can we solve the problem, right? So they have a hard time feeling any emotions. And in a couple relationship, in a parent relationship, oftentimes one is one and the other is the other in moments of extreme stress. One will go wobbly and the other will go head in the sand. But what we're looking to help ourselves and our family members to do is to convey the Saint Bernard. So the Saint Bernard is a dog of even-temperedness. They were trained to rescue people in challenging situations in the mountains and to provide a warmth and calming presence to help get the person towards wellness. So if you tend to jellyfish or ostrich, you want to try to work your way into the middle a little bit by imagining, what would the Saint Bernard do? How would they provide that sense of warmth and calm? All right, so those are the emotional extremes. And then we have types of caregiving extremes. So there's the emotions that we feel inside, and then there's how we do that with our behaviors, how we show the person outwardly how we want to care for them. So extreme number 1, kangaroo, overprotective. I just want to take that baby and put him in the pouch and do everything for him. I'll fix it for you. I'll take care of it. I'll protect you. I don't want you to run into the unknown without me, and let me hold your hand through it. These folks will tend to overfunction. They're great. They've protected their loved ones, but they tend to overfunction and get burnt out because they won't let go. It's hard for them to let go. And then the other extreme is rhinoceros. Rhinoceros, they're more controlling. They kind of wait in the background until enough is enough, and I'm going in, and we're going to fix this right now, and when we're done having this argument, no more. And they push for change and growth, and they, you know, they're the ones that are scooting the fearful ones out the door and say, or throw the baby in the pool and say, learn how to swim, gosh darn it. You know, I'm gonna tell you what to do, and now you're gonna have to go do it on your own. So again, extremes. Kangaroo, protecting in the pouch, rhinoceros, throw them in the pool. But actually what we're looking for in our approach to caregiving is just enough of direction like a dolphin. So the dolphin swims beside their little one or their person who they're supporting and nudges them when they're getting off course or when there might be danger near, but also allows them an opportunity to swim and make their own mistakes. So just enough direction to keep them from completely falling on their rear ends, but not to protect them from ever having an emotion. And I think what I've seen in the last 20 years that's been different is that we really have been hyper-focused on our kids not having any failures. You know, I saw it with my kids, like where everybody had to get the trophy on the soccer team, even though they didn't win a dang game. You know, we're like over celebrating them and not letting them feel like their own experience of anxiety about the test or the pain. And as I, you know, was involved in this big treatment center, I would see the individuals coming in not having known how to actually have emotional highs and lows, to let themselves go through the process of emotion. And then I think another reason for that is social media. You know, we live in an age where my stuff that I'm teaching you is actually not as much value because you can go on Google and figure it out yourself, right? You can get the content of this all on your own by going on the internet. But what you don't get the opportunity to do is in a relational way as much, especially if you're a young adult right now, to be able to go through an actual emotional process experience. That's what I want to help us to get back to and expand on and help our caregivers to learn how to do too. So that brings us to emotion coaching. Emotion coaching is a key to unlock the window of opportunity to get in there, to actually give them those caregiving skills that we have to help them to get well. And this is part one of advanced caregiving. So as you increase the role for the family member to be able to coach their loved one, you're also helping yourself from burnout and helping to support like the treatment experience, because this person they're going to be fielding the phone calls, getting the emails, getting the texts. Usually what happens, and I don't know about your experience, but my experience in a treatment setting, stuff comes up, they have a hard session with the therapist, the group was annoying to them, and eating disorders, that, you know, every meal opportunity is an opportunity for a meltdown. And they oftentimes are using those family members like, oh, you know, 3, 4, 5, 6, 7 times a day to vent all of their emotions. It's good for the family members to know how to handle those calls, and because they get tired of it too, of not feeling effective. All right, so what's your first impulse when you hear somebody say, a child says to you, Mom, Dad, I feel so sad, nobody likes me. It's your first impulse to do if you were going to soothe that person. Not your clinical impulse, but your first impulse. Is it probably to say something like, it's okay, it's going to be okay, everybody loves you, you're great, you're wonderful, I love you. What are you talking about? You're wrong. But how does that feel for the little one, you know? Like, I feel so sad. We're totally invalid, just as through our own cultural conditioning of how to respond. We inadvertently totally invalidate the person's feelings of sadness and feelings of being rejected. We're trying to make it better, right? If you're coming from that loving, protective place, we're trying to make it better. So why would we do this? Why do we do this? Well, there's a lot of reasons why. And one is that we want to protect them, right? The kangaroos in the room, you know, like, oh, that's okay. I've got you. Let me put you in my pouch so you don't have to feel that. We want to protect them from emotional pain, or their pain causes us pain. Oh crap, here I go again. I didn't do this well as a parent. I felt like a reject, and now I've created a reject, and I don't know how to function here. So just say the thing to make it feel better. We don't know what else to say because we haven't been given the language to do it. We surely don't want to make their pain worse. It doesn't make sense logically. I tell you what, I'm an advanced clinician, and still I have children that make me go back to level 1 every day. And one of the things that I don't understand is like the pain of homework, because I'd loved to do homework. And my 16-year-old tries to fight with me about how hard it is to fill out the attendance sheet so he can get credit for the class. I just don't get it, right? So then I say things that inadvertently invalidate him when he's trying to explain to me it's hard to fill out the attendance sheet. And I get all judgy like I'm doing with you right now. Like, come on, I don't understand this pain. Just do it. It feels like it's an easy assignment. And then we just weren't taught on how to respond to emotional pain, such as vulnerability or anger or feeling like failures, right? We're in a culture that says, just do it and be happy and, like work your way, like my family, just get to work and you'll feel better. But what we know about neuroscience is that each feeling comes with its own set of hormones and neurochemicals. And if we don't let them run its course, they get stuck in the body and serve to increase stress. So we want an opportunity for someone to have permission to have that emotion. Like, I feel so sad, nobody likes me. And to help them by validating them, like, oh, it is, I bet you do feel sad, and it might feel like this, this, and this. And let it run its course so it can be expressed. And the skill of emotion coaching and how we do this is it's kind of like bringing, when somebody's having an intense emotion, like feeling triggered, for example, feeling a trigger and I need help to my pain right now, really want to engage in purging. They're not going to respond to logic in the moment. Their brain has been hijacked by the intensity of the emotion and the pain. So our job is to teach ourselves and family members to get in there and how to bring them down to the ground floor of the elevator where reasoning and logic can then be inserted. But when they're at floor 10 with their emotions, reasoning and logic is only going to piss them off, right? Like, for example, when you're upset about something and somebody says, will you just calm down? Has anybody in the history of calming down been calmed down by that statement? No, it only escalates us further, right? You say, good, you know what you're talking about, and we get hyper aroused. So we can't like logically tell somebody to calm down when they're in an emotional state. We've got to go in and help them understand that we get it from their perspective. And this is, when we do this, we're going to be able to increase their cooperation, avoid escalation, and help them to de-escalate, and then get in there with all our best problem-solving skills. So not doing this didn't lead you to where you are today, but doing it can help you get out. So in the moments, our caregivers and ourselves as clinicians, we can help do this a little bit too. Caregivers are much more effective at it because they have the neurochemicals to actually help to calm the person down and get their limbic system back on board. Okay, so how do we do it? I want to make sure I give you this skill before we wrap. So how do we do it? Step one, we're going to convey with a genuine understanding of their experiences. Sometimes you have to kind of set your own judgments in your mind aside to be able to do this, right? Because we're looking at how can I prove that I can get it from this person's perspective, not our judgment about if we think that they're right or we're right, but that we understand it. So we're gonna practice a little bit of that. But before that we do, another thing that we commonly do, another thing to understand about social conditioning that kind of shoots us in the foot, is that we attempt to validate somebody. We can say, you know, I understand why you're feeling sad. And then we insert what word? It's a 3-letter word. It begins with a B. We insert the word but. I can understand, but you shouldn't worry about that. Or has anybody had a breakup? This was my favorite because I've had a few. I've had a few breakups that were very painful. And the worst thing that my girlfriend could say to me was, or my sister could say, is like, oh, I know that you're brokenhearted, but he wasn't good for you anyway. Right? It completely invalidates and they're just well-meaning, but it completely invalidates the experience that the person is trying to express. So we want to change but to because. I can understand why you might feel sad because you've just broken up and all of your dreams are shattered, and because you didn't want it to go this way, and because you spent so much time together. So when the external environment mirrors the internal experience, it reduces the alarm system in the brain, and that's what we're going for. Going for like understanding them so that they can go, okay, now I don't have to fight so hard to get understanding and reassurance. Okay, so I'm going to do emotion coaching with you so that you can feel it. So if you're here with us right now, you can like just kind of like, if you want to close your eyes or look down so people aren't looking at you. And I'm just going to emotion coach you so that you can feel it in your body. But take a breath. And I'm not going to look at your gallery views. I'll follow my own rules. And I want you to see if you can feel what it might be like to be emotion coached. So I can understand why you wouldn't want to involve the family in this case, because this client has a history of abuse and conflict with this family, because dad's probably going to show up drunk to the session. You worry about that. And because you just don't have the experience working with families, and you're worried that you're going to mess it all up and make it worse for the client. I'm here and I understand that. I believe in you. And just with a few tweaks with emotion-focused family therapy skills, I think you're going to be able to learn how to do this. So in essence, that's what we're doing with our caregivers. So what I did is I gave you a because, and well, maybe one of those hit and the rest flew by. When we're emotion coaching, we're just trying to get it. We're not pretending like we know, but we're trying to get it. Almost like throwing darts on a dartboard, like maybe this one will hit. I don't know. Can I hit a bullseye? And the ones that bounce off the dartboard, usually they don't make any difference at all. You know, the person doesn't usually get wrapped up in, Bonnie was wrong about that. I haven't ever had that feeling. But the arrow that does hit that dartboard, or the dart that does hit that dartboard, really helps convey the message of understanding. So when you do hit that, like, oh, that competence thing, yeah, that one was me. That's when we know we're getting you into a place where somebody is more workable. And then what I did was offer you some emotion support, reassurance. I believe in you. You can do this. That's what a caregiver can do. I love you. Give a hug, you know, hold a hand. And then practical support, which is all the skills that we probably have said a million trillion times over that they didn't listen to anyway, but that we already know how to do. A lot of us already know all these practical support skills. We just forgot to do the emotion validation at the beginning. And parents certainly have tried things over and over again, but where they're not being effective is they're not validating that they get it from the person's experience. I hope that makes sense. Okay, so that's if you want more information about that, you can go to the Emotion Focused Family Therapy book, and I'll also have some information on a workshop that you can send families to so they can start to learn to do this. So we've got some skills, we've got them in the treatment experience. We can teach the caregivers emotion focused family therapy, coach them on emotion coaching, and then also some tips and tricks that I've just learned along the way with family members as we're heading into, okay, what's it going to look like on the back end of this? You know, maybe family's done a great job in showing up for the family session or the family weekend or the family program that you have. Then what? So now what? We've taught some skills, they've had some successes, and then remember to include the family situation and members from the very beginning. Like, don't wait until week of, like, ooh, you know, maybe we should have gotten in touch with that husband. We've been doing all this work with the mom, but maybe the husband needs some support too. So go make sure that the family is included from the very first stage. And look for ways to do that if they're not giving you that information. And my former treatment center made a big effort in, I just got sick and tired, honestly, of people coming into treatment and saying that nobody cared about them, because it's just not true. And so I started, and the admissions team hated me for this, I'm sure. They didn't really hate me, but I'm sure they were frustrated when I said, I need a release to a family member. I'm not taking this person who's on death's door coming in and saying that they have nobody to support them, because you know what? Then they're going to stay in treatment for the rest of their lives, because then we become the family system. Well, we got to help this family system. We don't need them in treatment forever and ever. Of course, we want to give them a good course of treatment, but in the eating disorder space, oftentimes we would have a bigger problem getting people out the door than in the door. And that was because they had fearful that, like, there's going to be nobody to support me when I go home. So I started making sure that folks had, especially if they were like 18 and they're like, I'm an adult now, like, no, you're on your parents' insurance and you're driving their car, and they're sending you money. So I don't think you're an adult yet. You're maybe an employee of your parents. And then while the person's in treatment, this is a great time to encourage the family to get their own support, take vacation, focus on the other siblings, like go home and rest. Be ready, because I'm going to need you. So get working on yourself now if there's something that you feel like you need support on. And one thing that I would say, another thing I would say actually, is that COVID has allowed us so much more availability of virtual online support groups. Getting people to go, family members especially, to go to support groups, like to leave work and go do the group before dinner. That was a struggle, but now you can attend those support groups right from the comfort of your own home. So let's take advantage of that. And there's plenty out there now. And then less is more. So always slowing yourself down and the family down. If somebody has needed to go to a treatment episode to get help with their problems, they're not going to fix all of that in 30 days or 90 days. Like, so slow them down. It's going to be a long road of recovery. And then ask yourselves, can adults in recovery really be independent? Are they ready for independence yet? So car rental companies know full well they're not going to rent cars to folks until they're 26 years old. You have to have somebody co-sign for you. The brain doesn't really become fully adult until well into the 20s. And as I mentioned before, our families are oftentimes, supporting them in some extent, and they do have leverage. So let's help them to have that. How do we do this? We establish in our treatment centers the expectation of including somebody for support. Don't just take carte blanche. I'm an adult, I want to do this on my own. None of us can do this on our own. Really, we all need people. And we need our pets, we need our people. We can't do this on our own. And who's to say that the family is not just as important as the person in support groups too? So consider case management models and continuing care models. Like, that person doesn't have to have the interventionist in order to do this. There's a lot of programs that help involve families in case management. And remembering that our people do not recover in a vacuum. They recover because people around them help them. And we can't be their family system. As much as we would like to, just like they can't be our family system, we cannot be theirs. So help to expand the support for caregivers because they need support too. And just a little tips on like coaching for life transitions and finances for family members. I found it's oftentimes helpful to tell them it's a question of when and not if, you know, because they'll come with a question like, should I continue to financially support them? You're like, well, not forever. And how do we get there? But right, cutting them off right now isn't going to help them. So what are the priorities? Maintain their insurance, making sure they've got their medicine, monitoring systems, like going to their, you know, getting their sobriety monitoring, food, school, communication methods, and then start to develop a 6-month plan for financial freedom. For example, start with dropping the things that are non-essentials that aren't going to really do a lot of damage, like Spotify. Note to self, I'm going to do that for college student I have. The Xbox membership, you know, things that they can learn to take on for themselves. Note of for treatment folks, they tend to have wonderful connecting experiences in treatment. They find a friend or they start a relationship and they want to move in together and sign a lease, or they ask you as the parent to bring their friend home with them. Please don't ever do that. Tell your family members not to do that. It doesn't work out. People who are new in recovery are likely to trigger each other. They can be friends, but they should not be living companions. It can be really helpful for family members to, if you want to make use of a family member, put them to work to go shopping, to stock the house, and to create a monthly calendar. Like let's get everything that this person is going to need to keep track of in a calendar, and then you can go over it together in session. It'll be really useful because it's overwhelming for somebody in recovery to think about all the things they need to do each week, but it's certainly comforting to have that structure and schedule in place. And then last but not least, and especially around the holidays, to plan supportive activities together, right? So make a conscious effort. What will we do if we're together? And it's not about food and drink. Maybe we do a puzzle together. Maybe we take a walk together. Maybe we, get out the art supplies and or find something online, a cooking class that we do together. Caution if you have a person with an eating disorder, that could be triggering. But really try to think about not what are we going to have for dinner and who's going to be drinking what, but more about what do we do in free time just with each other. Plan a white elephant gift exchange, what fun supportive activities as a way to spend time together, or just, and this is a popular one in my family, hey, why don't we put on some music and we all get our favorite book and we'll sit by the fire together. Just being in each other's presence. Okay, well, and if you are interested in got somebody you think could use these skills, I am going to be doing a workshop in January. It's a 2-day parent caregiver workshop, which I teach all these emotion skills and more to family members with each other. And for those of you who might be a clinician and a family member supporting somebody with a mental health challenge, if you choose to come, I just ask that you come with your family member hat on rather than your clinician hat, that you get to be taken care of in that sense. So you don't have to be worrying about being a professional. And then I have, Laura, I think I sent you a PDF that you could send to them, or you can see the link at the bottom too.
Yes.
Okay, that's enough of me talking. And now I would love to hear questions from all of you.
Okay, great. So thank you so much, Bonnie. This was amazing. I never get sick of the EFFT. And every time I hear it, I get a little tear. It doesn't matter. The minute that you start validating the person, it just brings up all of my old stuff too. And I can't help but start immediately feeling more vulnerable and open to it. What I'd love to do, we can try to do a hand raise if anybody has questions, or if they could just type them into the chat. That would be great. We have about 19 more minutes so that we can do some of the questions. So I'll await some of the chat ones. In the meantime though, Bonnie, how do we get EFFT and that component out? So I know for me as a certified recovery coach, we sort of try to use that as well. But besides your class that you're doing once, I think, a month, is there any other resources that we can provide to people so that they can start learning some of the language?
Yeah, sure. There's so EFFT has an umbrella called mentalhealthfoundations.net. So you can go to that website too. And they have clinical trainings. So they have trainings for clinicians to learn how to be a clinician with EFFT. And then they also have other parent caregiver workshops too. Or you can get the book right here. It's a good one to read. Yep.
Okay, great.
And people, if people want to, I don't know if they can unmute themselves. But
yeah, we can all unmute. We can have a group chat. There's only 19 of us, so why don't we do that?
I'm gonna stop. Did everybody get the information there? I'm gonna stop my share so we can see each other better.
Yeah, and we'll send that out also afterwards. So
what questions come up for folks as you think about including, or maybe what brought you here today? And did I answer any needs that you had, or maybe you still have some more?
Well, I guess I can have a question. So when you're validating someone's experiences and you say because, how do you, I guess, you're going to listen and try to understand, but if you're also trying to help, how do you direct them appropriately, so to speak, in a good direction while you're also still trying to validate their feelings? So it doesn't come off as, hey, they're validating, but they are pushing me or in a direction that doesn't feel like I understand the direction that they're pushing me. And I don't want to say pushing, but guiding or leading. Like you said, you got to learn how to follow and also lead. So how do you incorporate that into the validation process?
Yeah, so that's a good question. And, you know, oftentimes in treatment, like in eating disorder treatment, you got to get the person to eat, right? So that can feel like pushing, right? And so you would, an example like that, maybe you would, or let's say the kid doesn't want to go to school, or the person doesn't want to, you know, the person doesn't want to stop drinking altogether. Let's use that one and say, I can understand why you might have a hard time letting go of alcohol use because it's numbed your pain, and because it was a way that you found that you could connect with other people. And because a lot of your friends and even your partner are still connected to using alcohol, and you're worrying that you might lose them if you were to give it up completely, right? So you're validating all the emotional reasons. And then you say, give them a emotion support around that. I hear you and I understand how hard this would be, or I can only imagine how hard this would be for you, but I'm here for you. I want to help you navigate that. And then you insert their practical support. And let's say you're recommending that they go to a meeting. And hey, listen, I can help you find one meeting, just one meeting. Let's take this one step at a time. And let's get you to that meeting. Let's look it up together.
Okay, so you validated, explained what you're trying to do, and then suggested instead of, hey, I think this.
Right.
Hey,
oftentimes we go to the meeting and then we try to explain ourselves like, this is why you should go to the meeting, or this is why you should stop, you know, with your vegetarianism, or this is why you should go into, so we go to step 3 before we've done step 1 and 2. And then what we've said to them is, I don't understand you completely.
Yeah.
And we get into that fight of, well, you don't understand me because I don't understand you. And so it's our job to be the coach, is to really make the effort to go first to understanding them.
And it sounded like you gave them a choice, right? Hey, I know these meetings, these meetings, whatever you say, you know, I know that these work. Maybe let's look into one. What do you think? Kind of deal. Like,
yeah. And
you always give them a choice.
Yeah. And you can you can be that way, you know what's, and so a lot of times instinctually we have a feeling of like, how hard do I need to push here? But sometimes we need to push hard. Sometimes we need to say, and you're there, it's not an option for you to not be in treatment right now. So I'm going to support you to make this a little bit easier while you're doing it.
Okay. Okay. Thank you.
Yeah, you're welcome.
Okay, thanks, Bonnie. Olivia Rigatti, you have a question?
I do. So regarding how families are hardwired into each other, and I'm gonna use a personal example from my life, but just you can answer it in a more general way. It's not specifically about me, but just in treatment, how this can work. So so you have someone, say, that's in treatment, that is, whether it's substance use disorder, eating disorder, or what have you, and they're coming from a broader family system that has dysfunction and mental illness, whether it's the same situation that's going on within the family that the individual in treatment suffering from, or a varying degree of other mental illness. And that is very hardwired in systemically in their family system. So my example that happened with myself is I've been in therapy my whole life, adult life and high school and everything. And my family system communicates very poorly. My partner and I, couples counseling for a very long time to learn how to communicate appropriately, have gotten to a decent place. Nothing's perfect, but my dad came and stayed with us for a week in the summer, and everything was cool, no issues, but somehow the wiring just like in my brain went back to my normal family system wiring. Dad leaves, everything was chill when he was here. My partner and I got into a disagreement about something that normally wouldn't have been a big deal. I reverted back to my poor communication family system style, got real, pardon my French, shitty with him. And it was exactly how my parents would communicate, how I would communicate with them, like just nasty. And to me, it took a couple hours of me processing that and feeling so righteous in myself, like, oh, I'm right. And, what he had done was not great, but it was an easy, like, hey, the thing that you did, that kind of sucked. And like, maybe don't do that again. And him being like, yeah, that you're right. Okay. That would have been our normal interaction. Instead, it was like hours of me screaming and crying and
Right.
going down to the basement. I'm going to sleep on the
Emotion.
couch. And
Yes. Yes.
and it was very interesting that it was that quick to slip back into my old family system way of thinking. And so when you're working with somebody in treatment and you're incorporating their family, but you can't fix their family system in that. How are you managing that if you're sending them back into that family system and that's their support?
Yeah.
How are you incorporating that in
That's why I want to
treatment?
get them, right? You want to get them in there. And so let's just say, since you used your example and you shared that. So like if you were, let's say, pretend you were my client, right? The first person I would want is that partner, because that's the one that you had all the emotions with. Dad came to visit, right? And it was okay, but the safe one was the partner, right? And then all the emotions came spilling out onto the partner. So I would want the opportunity to help that partner with, here's how you emotion coach and recognize when somebody's in that limbic state. I was sharing with Laura when we were talking about this workshop, like how I got a letter in the mail and it, like, I became a complete nut because it was an unprocessed emotion that went all the way back to when my father used to go on business trips as a child. But emotion doesn't know time and space, and it's just looking for an opportunity to be processed, which is why it comes out in such weird ways. And it's not your partner's fault, right? It's just that it came out and you're having all this stuff and he's probably trying to figure out how to do it. So emotion coaching you in that situation would have maybe been helpful. And so you would start with somebody who's in treatment is to say, and I do this with my clients, my individual clients, I need somebody who I can teach, especially when they're having difficulty with emotion, how to support you when you're not in session with me. Because once a week with Bonnie isn't going to cut it. You're going to have other things come up, and that person can be trained.
Yeah, unfortunately with me, I've been through so much therapy that, you know, an hour or two went by and I was like, whoa, that's how I used to be. And then I apologized and was like, I am so sorry. Like that, you know, what you did sucked, but like I reacted so crazy. That was like 15-year-old Olivia, my bad. Like, can we be cool? I am so sorry. And it all worked out, but it was interesting that it was on the tail of, you know, just a family interaction. And it was like that little buried part of my brain had lit up from my family system that like, oh, this is how we do things. I've been hanging out with my dad. This is how we talk. This is how we do things. This is how we communicate when we're angry.
Right.
And it was
that
so
memory
easy
too. The emotion that didn't get an opportunity when you were a child. And oftentimes that stuff that we're triggered about goes way back to like before age 12. That we just didn't get an opportunity, not because we had bad parents necessarily. You know, they were just human beings.
Oh yeah, for sure. So it's something that you work within the family system, but even if you're not able to heal the entire family system to be a normal functioning, not normal, but you know, functioning, better at communicating group as a whole, that individual can recognize that and then be able to identify it moving forward.
Exactly. And remember the 1 degree effect, right? So we're looking at, so the next time, or for in my own life, if I'm having a meltdown, I'm going to want my partner, I keep saying the words like reassurance is what I need. By the way, reassurance, not problem solving, just reassurance that you can do it. And say the words. You must be needing some reassurance right now. And, you know, it's okay. And the nice thing about EFFT is it has scripts, which can provide a safety net so that you see your person. So when I have somebody doing an emotion coaching, they've got a script in front of them where they're actually reading, I've been thinking about this, and I'm going to read exactly the words to you so I don't mess it up, which is also a nice part of it.
So if I'm working with a family, say, trying to help them navigate their family member getting into drug and alcohol treatment, and the family member is resistant and the parent is also resistant because they're resistant, saying, oh, they're okay. Like, no big deal. Like they were in treatment for 10 days and they left AMA because they said that they're fine and they didn't need that kind of treatment. That just because they've been using fentanyl doesn't mean that they just aren't as bad off as those other people that were in treatment. Using that, the because, and those type of validating statements to try to help motivate them to understand that, yes, you're having these feelings, that you're listening to this person, but because, validate your feelings, but let's try to get you into at least a meeting or, you know, see a therapist at minimum, not, you know.
Or just using it with a family member, right? Like you're saying, like, I can understand why it may be hard to think about making them stay because they're wearing you down, because you've spent so much money, because you're worried that we're just going to keep repeating this cycle and you want to move on with your, whatever it is, you know, there's lots of reasons. And then you insert that emotional support. I totally get it. I hear you. Like, you must be exhausted. And then the practical support, which is, and I never give up hope for people in recovery, and let's give this a go while we still have the insurance benefits, or whatever you want to say to do to help them. Yeah.
Okay. Great.
Yeah. Thanks for asking. Good questions.
Okay, so we have about 3 minutes left if anyone has as we call it in the rooms, a burning desire. And if not, I think at this point we'll probably end this on a very high note. Bonnie, again, I want to thank you so much from both Gallus as well as from AspenRidge. We are delighted that you joined us for this.
Thank you.
Everybody that's on this call, a few people had to leave early and actually sent us messages on the side, so we will be sending this out. And again, look forward to some more really great events with Bonnie Brennan, as well as with Gallus and with AspenRidge. And thank you all so much for attending, and have a wonderful holiday season.
Thank
Bye,
you,
everyone. Thanks for
everybody.
coming.
Thanks, everyone.
Thanks, Bonnie.
Good luck validating.
Bye.
Bye.
Because.
Bye.